So.
Mhm.
Can you hear me?
Miss Sally, can you see your slides?
I can. Can you hear me?
Yep. Sure can.
Perfect. Are we ready to start?
I believe we are. People are still joining, but I think in the sake of time, we'll go ahead and get started.
All right. Well, I'll introduce myself real briefly. My name is Sally Snow. I am a longtime friend of the EMSC and the Pediatric Readiness Project Steering Committee and the EMSC program. I have been a nurse for more years than you need to know, almost 50, and I am currently a retired emergency and trauma nurse, pediatric focused mostly for most of my career. And I do some consulting work, as you can see, with the EIIC and some other folks, but that's why they asked me to help with this.
Oh, I'm sorry. 297-8776.
Just a reminder to everyone to please mute. This webinar, this breakout isn't automatically muted. So if you could please mute so we can hear Sally. Thank you.
I'm pretty good at talking over people, but it's easier if I don't have to. Okay, next slide, please, Lisa. All right, this may look a little familiar. In fact, I think we saw it a couple of times before. But you know what they say, you have to say something 3 times before people get it sometimes. So let's go with the 3rd time. So what are policies and procedures supposed to do for us? Please mute, guys.
Yeah, that's fine.
Kaylee, can you please mute? Thank you. Sally, you're muted.
How in the world did I get muted? Did you mute everybody? It's okay if you did. All right, we ready to? Let me get back in business here. All right. So again, what are policies and procedures supposed to do for us? Well, they should lead us to lay out what we expect on a particular subject with the goal of achieving safe and high quality pediatric emergency care. That's number 1. They need to be simple, uncomplicated, focused statements that are clear and concise. They should provide for a way to bring down cost and bring efficiency up. They should provide a path that decreases variation, errors, and reduces confusion. And it should be clear who has accountability, and really everybody who's responsible for following a policy and procedure, it has accountability for it. But most important, it's in this process is to find and utilize the experts and the resources available to get the policy right the first time. Next slide, Lisa. So you should answer these questions. Why do we need this policy? If you can't answer that question, maybe you don't need it. It's something you need to decide up front. Ask yourself, is this clinical or an operational policy? What's the subject we're trying to define? Always keeping in mind values, vision, and culture with simple, appropriate language. Are there boundaries or constraints? And what expectations do we need the policy to meet? Is it flexible? Are we adhering to a standard format established by the institution? What is your institution's policy on policies? It's always best to read that first. And finally, who's responsible for the policy and who is affected by it? You must get input from the end user, the person who has to implement the policy and procedure and adhere to it must have input to ensure it's successful. Next slide, Lisa.
Okay.
So let's talk a little more specific about policies and procedures. Now, what are some of the policies you need in place to care for kids? Obviously, there are more policies needed than these, but in my experience as a facilitator, sometimes reviewing PEDS-ready facilities, these are some of the ones that I see that are often missing or may need the most work. Next slide. Recognize this little icon. I thought it was brilliant to put this in here. You'll see a lot of it during this presentation, because I really want you to think about what questions you may have as we talk through these policies, understanding that I'm going to provide you with some sample policies at the end. If we have time, we'll look at a few of them, and I'll give Meredith or Michelle and Lisa all of the policies that I have to share, and then you'll be able to look at them at your leisure. Next slide. So let's talk about child abuse screening, recognition, and reporting. This is extremely important, especially in a general emergency department where staff may not see or recognize subtle signs of abuse in low volume EDs. In nonverbal children, child abuse is often missed or overlooked, and it can be devastating, and the consequences are lifelong. So what's the purpose of a child abuse policy and procedure? Should the focus be on the patient? So your purpose statement leads with something like, all suspected or obvious cases of child physical, emotional, sexual abuse and neglect are identified and reported, ... What about a focus on the law? Should we lead with the presence is to ensure compliance? The purpose is to ensure compliance with laws and regulations? How about a focus on the hospital or the staff? Should it state the purpose of the policy is to present an overview of steps to be taken by the staff when child abuse is suspected? Perhaps a combination of all those is appropriate. I think the order is important, and the primary focus should be on the patient, the child. Next slide, Lisa. So in your policy statement, you might see things like this. Suspected child abuse should be reported in accordance with hospital policy and established law. Or all hospital employees and physicians must comply with state law for reporting suspected abuse. Or how about all pediatric patients are screened for evidence of abuse and managed in accordance with established standards and laws. The policy can be extensive, may be very extensive, including things like the plan for education of staff who are responsible for that. I'll show you an example of that a little bit later. It should include a statement regarding screening of all children with a standardized validated screening tool. The evidence shows that EDs are 5 times more likely to detect abuse if it's present when using a standardized screening tool. That's a significant increase in the number of kids that you'll identify as at risk for abuse if you use a screening tool. It's highly recommended that you do that. Mortality increases with recurrent episodes of non-accidental trauma in children. And we never want to hear that a patient that we discharged came back critically injured or dead from child abuse that we missed the time before. Next slide, Lisa. So your definitions in your child abuse policy should include who's required to report by law. These are legal responsibilities. The legal department can inform you about that. In my state, Texas, the Texas Family Code lays out who are mandatory reporters. The penal code in some states lays that out, but those kinds of things should be included in your definitions in your child abuse policy. You need to define the types of abuse. So what is physical abuse? What's emotional abuse, sexual abuse, neglect? Some policies include a statement about exploitation and willful intent. How detailed these specific definitions are in your policy is entirely up to you. You may want to just refer to an appendix with all of the detailed definitions. That's entirely up to you. General EDs may add child abuse to their elder or vulnerable adults abuse policy, but there needs to be specific pediatric definitions defined and spelled out in your policy if it's included within your adult policy. Next steps. Next slide. The procedure should definitely include the use of a standardized screening tool. There should be detailed, documented instructions of how to describe injuries, how to document statements of the patient and the caregiver. We know those need to be done in quotes verbatim. Notification of law enforcement, child protective services, or whatever your state calls child protective services. Social worker documentation is important. If a forensic exam is performed, that needs to be clearly documented. If there are issues of chain of custody of evidence, those need to be defined. What consulting services are needed in your hospital? Who admits a patient that's been abused? My experience is it's always trauma. Trauma admits for the first 24 hours in a verified designated trauma center. That's pretty much the way it goes. What other consultants do you need? Do you have a child abuse pediatrician? The hospital where I spent the majority of the last few years of my career, we had a team of pediatric sexual assault nurse examiners, nurse practitioners, a child abuse pediatrician. We called them the care team, child abuse resource and evaluation team. And they were the experts. They did all of the evaluation of child abuse patients. They consulted on all of them. And just as an aside, I'll let you know that in Tarrant County, Texas, before there was a care team, there was no conviction of a child sexual assault defendant without a confession. After the care team was implemented and we got the experienced sexual assault nurse examiners and our child abuse pediatrician, we convicted lots of sexual predators in Tarrant County, and that's an important thing to do. Is a transfer warranted for a forensic exam or a higher level of care due to the child's condition? That needs to be part of the procedure. We need to document disposition. Will the child be discharged, admitted, or transferred? And this is a policy that needs a quality review component to assure compliance. I'm going to share a recently approved child abuse toolkit, which includes a validated screening tool and interventions that were developed by the Pediatric Committee of the Texas Governor's EMS and Trauma Advisory Council with Meredith and Lisa and Michelle. And so you'll have that, and it will really help inform your policy and procedure development. I'm also going to provide several examples of complete policies that are shared with me, that were shared with me by my colleague Nancy McGrath from California, who's one of the original PECs in the California EDAP program, and that will be very helpful to you as well. Next slide, Lisa. So what about the purpose when it comes to a child abuse policy? Is there anyone in this group? Wait, I'm talking about triage now, aren't I? Hello. Okay, let's move on to triage and reassessment. We beat child abuse, no pun intended. So the purpose of a triage and assessment policy is to establish the process for providing initial assessment of patients arriving to the ED for care in accordance with evidence-based triage practices. Is there anyone in this group who's not using the Injury Severity Index 5-level ED triage program? I know that if we have international participants, that could be different. I know Canada has its own ESI. I hope you're all aware that ENA now owns ESI, and they've recently made available a continuing education module for pediatric ESI that can be accessed on the new ENA University website. And I'll put that in the chat if I get a second in a minute. In full disclosure, I'm an ENA member and the chair of the ENA Foundation, but I highly recommend this resource for educating your nursing staff on ESI, especially around pediatrics. The other purpose of the policy on triage and reassessment is to establish parameters for when and where to reassess patients and what that documentation looks like. Next slide. So you need to define your triage levels with pediatric specific examples. I've looked at many a triage policy in an adult only or primarily adult facility that doesn't include the specific examples of what a level 1, a level 2, a level 3, a level 4, a level 5 look like when it comes to kids. So it's important that you have specific pediatric examples. Some hospitals are using screening staff like a paramedic to quickly assess patients for more urgent need. Some have a nurse called a router nurse who quickly determines who needs to be seen or who needs to be directed to a treatment area. So how do you manage patients arriving via ambulance versus walk-ins? Those need to be defined. What vital signs do you take at triage? Does anyone get a full assessment? Does everyone get a full assessment, or is a focus assessment acceptable, and when? That needs to be spelled out. Do you directly bed patients? Do you send some to the waiting room? What kinds of nurse-initiated interventions do you have in place? Can a nurse order an X-ray on an obviously deformed forearm? Can they order lab? Can they do a strep screen in triage? Are you giving medications for elevated temperature? So those kinds of nurse-initiated interventions need to be spelled out, or at least referenced in your policy. One of the things that's complicating this a little bit is some expanded use of providers in triage that's necessitated in some cases, a complete overhaul of the screening process up front. So that's something to keep in mind if that's something you're doing. Next slide, please. Some policies benefit from the use of a figure like this triage algorithm. Visual cues are helpful and draw attention to materials that are important. It provides information at a glance, including this danger zone vital signs that's included in this graphic. Next slide. Use of graphics and pictograms is helpful. This reference to the pediatric assessment triangle helps focus on those patients that need immediate attention. Besides, they're nice and colorful and they draw people's attention to them. Next slide, Lisa. If patients are directed to the waiting room after triage, a policy needs to guide how often those patients should be reassessed. If medications are administered, response medication needs to be documented, as in fever control medications. So if you're giving a kid a Tylenol before you send them out to the waiting room, you need to be able to have a method to reassess those kids if they don't get back to the treatment area in a timely manner. It's important to teach triage nurses to instruct parents to come back to triage if the patient's condition changes. What is the expectation for reassessing patients during their ED stay, whether they're in the treatment area or not? What are the documentation expectations? Your policy should also address triage red flags, and you may include a table for how to manage fever in children. I'll show you an example of that in a few minutes. ENPC and other references can help identify what should be included in this list of red flags. They're pretty obvious, but it's important to have those kinds of things in your policy. Next slide. So let's talk about the vital signs policy and procedure next. The vital signs policy can be a standalone or part of the nursing assessment policy. For the purposes of this discussion, we'll talk about it as a standalone. So the purpose of a vital signs policy is typically to establish what vital signs should be assessed on patients and when, and under what circumstances they should be reassessed. And then when should abnormal vital signs be reported to the provider. Next slide.
Test you. Your doctor's office order a test, or are you gonna go to the mall? The mall's gonna have a physician's order. Yeah, I think they have a rash at the mall. Yeah,
Tara, can you please mute yourself?
and inside the mall, I don't know where, but it's probably water and inside the mall.
So what kind of definitions do you need in your vital signs policy? Definition is necessary to establish the policy for what vital signs should be assessed and when to notify the provider of abnormal findings. Education is really important to establishing the guideline and should be developed with medical staff leadership to avoid conflict between docs and nurses when notification occurs. Everybody needs to know up front when to expect to be notified about an abnormal vital sign. It should include weighing patients in kilos only, and documenting a pain assessment using age-appropriate pain scales. Include a figure with those pain scales in your policy. I know this is more assessment than vital signs, but you can't mention it too often. Frequency for repeat vital signs is an important parameter to consider in your policy. Don't make the policy more stringent than you can comply with, and conduct frequent review of records to determine compliance. You can always take more vital signs than the policy states, but you can't take less. So your vital signs policy should say something like that you repeat vital signs as a patient's condition dictates. If you think that certain levels of patients should be repeated Q15 or Q2 hours or Q4 hours, pretty much everybody thinks that vital signs should be repeated at some point before discharge, admission, or transfer. But don't say in your policy something you can't comply with. That's certainly a legal red flag. Next slide. So pick a normal vital signs reference and provide the staff with badge buddies or normal pediatric vital normal pediatric vital sign parameters. It's especially important in a general ED where the volume of pediatric patients is moderate to low. Posters and triage and resuscitation with normal vital signs is important. In the resuscitation room and the triage room, make sure your normal vital signs reference matches your EMR, and the alarm parameters include pediatric values. I've seen many EMRs that don't break down incremental age groups for pediatrics. It's just all pediatric vital signs are clumped into a couple of age categories, if not only one. So make sure those match. Establish the when and why and how providers will be notified about abnormal vital signs and how that notification is going to be documented. The provider doesn't need to know if a school-age child comes with a 101 temperature when they sign in, if the patient's not had an antipyretic and has a normal level of consciousness, a normal heart rate and respiratory rate, they don't need to know about it right then. On the other hand, an infant with 101 temperature is a reason to notify the provider. So make sure those pieces of the policy and procedure are well in service and everybody agrees to what is important to do. Notification of the provider when a patient has abnormal vital signs is one of the bundles that we used in the Pediatric Readiness Quality Collaborative that took place in 2019 and 2020. When we first started looking at that, we found a deficit in a lot of ERs, but a quality improvement effort with education of the staff resulted in a lot higher compliance. So it's something you can turn around. Next slide. So let's talk just a minute about patient family-centered care. Some of these concepts may be difficult to implement in a general ER, but I'd submit to you that a sick or injured adult would benefit from the presence of a loved one most of the time. I know I would. For the purpose of this discussion, though, let's talk about why family-centered care is important to the care of children and their families in the ER. Parents and caregivers know their child's baseline best. So they know what it looks like when their child is in pain. They know what calms them when they are upset. So it's really important to have a parent and caregiver with the child at all times. The perspectives and information provided by families, children, young adults are essential components for high quality clinical decision-making. Decisions made together as a team are more likely to succeed. Patients and families are integral partners with the healthcare team. And again, from a buy-in perspective and a compliance perspective, you need those people to be with you. Evidence validates that there's a direct correlation between patient satisfaction and family-centered care in which nurses play a vital role. Now, we don't always want to talk about patient satisfaction, but it's a reality. And it's proven that having the family involved from the beginning is going to improve your patient satisfaction scores. Next slide. In terms of definitions, you want to define patient family-centered care. Patient and family-centered care is an approach to healthcare that is grounded in the mutually beneficial partnerships among patients, families, and healthcare providers. The American Academy of Pediatrics, American College of Emergency Physicians, and the Emergency Nurses Association has a joint policy statement on patient family-centered care in the emergency department that can help inform your policy statement, purpose, and procedure. I'll share that with Meredith, and she can share it with you all. One of the things that it includes is an assessment that you can do on your ER to help you assess whether your ER is ready for is family centered. We'll also talk in a few minutes about family presence during procedures and resuscitation, which is decades old and evidence based. So what about family goals and outcomes when it comes to a patient family centered care policy? Each child and family should be empowered to make choices and decisions. Organizational policies, procedures, and provider practices should be flexible so that services can be tailored to the needs, beliefs, and cultural values of each child and family. And the healthcare team's communication should be collaborative with patients and families, integrating their feedback into the care for the patient. In terms of assessment, look around. Is your ER child and family friendly? Next slide. Some of the interventions you might address with your family-centered care policy are, do you have a welcoming environment? What kind of information are you providing to parents and families? Do you individualize the approach? Is there a discussion and review of the plan of care? You want to involve parents in every aspect of the patient's care, encourage family presence, foster open communications, and develop trusting relationships. Next slide. So let's talk for a minute about family presence. I hope that everybody listening to this workshop today is doing some form of family presence. Family presence during procedures and resuscitation, again, is a decades-old concept that's evidence-based, but in some settings still meets with resistance, especially from some physicians, administrators, and sometimes the lawyers. The policy should be clear about when family can be present and under what circumstances they may not be present. It's very important that the concept be fully embraced by the organization, and there must be buy-in from the medical staff. Surgeons and surgical subspecialties are especially important. The last thing you want is a neurosurgeon walking in and trying to kick a family member out during a resuscitation. Families have a right to be present under the right circumstances. Staff safety has to be the highest priority. And family presence during resuscitation does not typically result in any disruption of resuscitative efforts. It's essential that a dedicated staff, social worker, or chaplain be assigned to attend to the needs of the family. Certainly, the evidence indicates that families begin the grieving process sooner and may, in fact, be the ones who ask that the efforts be discontinued. And there's no evidence that litigation is increased when families are allowed to be present during resuscitation. Next slide. So in summary, when developing your policies and procedures, don't reinvent the wheel. There are people out there who are willing to share policies and procedures. The EIIC has them. The National Pediatric Readiness Project has a toolkit for pediatric readiness that has tons of them. Utilize your experts and your professional organization resources. Use the EIIC toolkit for Peds Ready. Get input from everyone involved with implementing the policy and procedure, and educate the staff with every new and revised policy rollout. I want to thank you all so much for your participation in this collaborative. You're doing such important work toward making the EDs in this country pediatric ready and championing the pursuit of excellence in pediatric emergency care. I thank you for the opportunity to talk to you about policy and procedure development. I'll be sharing lots of resources with Meredith with sample policies that you can adopt and tweak to fit your hospital's needs. So let's answer some of those questions that you've put in the chat. What do you got, Meredith and Lisa, or Michelle and Lisa? I'm sorry.
The slides will all be posted just after the presentation. They aren't able to be posted at this moment, but they will be posted this afternoon. I know we had lots of questions about that. Do your policies in specific ESI levels that a pediatric patient with suspected NAT has to be? And also if they must be seen by an MD, or can it be a mid-level?
I don't think there's any specific rule about whether they can have to be seen by a physician or mid-level. I mean, obviously at some point, if there's going to be an admission or a referral to a child, a forensic exam, then a physician's going to have to, may have to see them. Tell me the first part of that question again, Michelle.
They were asking if there's a specific ESI level for non-accidental trauma.
You put in the policy.
I don't have the ESI in front of me, but I think it depends on the condition of the child. I typically see suspected abuse or concerns for abuse being given a higher level because it does require additional resources.
I think we usually do a minimum of a 3. And if they have like significant burns or anything like that, you're gonna have of course, a higher level.
Right.
Let me start at the bottom here. Lots of questions about, do you require blood pressures on every child?
That really depends on the institution and the physician leadership and nursing leadership. The Peds Ready material says yes, you should do a blood pressure on every patient, because if you don't do a blood pressure on a 3-year-old, how do you know that they have hypertension and may have some some early onset kidney disease? So yes, there is a way to get an effective blood pressure on every child. Now, is it mandatory? It's something that you have to decide as a group of leaders, nursing and physician leaders, and make part of your policy. But if your policy says you get a blood pressure on every child, then you should get a blood pressure on every child. What do you think, Michelle? What do you guys do?
I think so many people try and focus on a certain age to get a blood pressure, and that really should not be the consideration. It should be, are they acutely ill? We require blood pressures across our system, even in our community EDs, for anybody that's an ESI 1 through 3, and then 4 and 5, if they're stable and look great, then they can get those in the back. But blood pressure is really important, especially as we look at sepsis across the nation. Has been a big focus. You really need those blood pressures. So I think, and people I think are afraid to do it on young kids or think they can't, but it is important to really be able to get a blood pressure on a young child and infants.
And it really does take a technique and practice and knowing some little tricks of the trade about what makes it easier. I mean, sometimes just your language. If you can just say, do you mind if I hug your arm, or can I hug your leg down here? It's just a matter of knowing how to approach the parent and the family
and
about getting a blood pressure.
And utilizing distraction.
Exactly.
You can get them to watch the numbers and watch them go down, and it's talking them through it.
Give them something to play with, a toy to hold, or it's definitely all about the technique.
Yes.
I think that we found in our adults a combined ED that you see the majority of the patients you see are in adults, and it's go in, take their blood pressure and leave. It takes a little more time, but you can figure out tricks for the most part. Now, every child is not trickable, but for the most part. I think it's just convincing folks that it'll take a little bit, it might take you a little bit longer, but it's a very important number to have in your overall picture of a kid.
And
Yeah, and
document,
I've even seen nurses get the parent to let them get their blood pressure taken. And once the kid sees that it doesn't hurt, mom doesn't think it's a bad idea, then they're cooperative. But you're rightly said, it takes time.
yeah. And document why if you can't get it. If you
Right.
have a policy that says that you have to get it, document why you can't get it. If you have a kicking and screaming child or they're going ballistic, well, they're probably not hypotensive. So document what they look like and what they're doing.
I have a question.
Yes.
So I work in a general ED. We have about 12 to 1,500 pediatric patients a month. When looking at pediatric readiness certification and full transparency, this section is the one that like weighed on me the most. Maybe that's the administrative side of me going, oh my gosh. So I just wanted to ask a little bit of guidelines. There were, when I used the toolkit and I'm on the website, it gave samples of different policies. And at our organization, we have quite a bit of policies related to our pediatric population. There's not a set expectation of you have every single policy on a particular aspect. You provided samples that guide the care, but not necessarily that you have to have a policy that matches each one of those. Am I correct? Or
I think if you look at the PEDS readiness, the National Pediatric Readiness, it does have a list of policies that you should have.
it does. It says this is a sample of relevant policies and
Yes.
procedures.
So they actually use those when they're scoring to give you your score for your pediatric readiness. It doesn't have to be a separate policy for your pediatrics. It can be intertwined with your adult policy. Like
which
at our community.
many of ours are.
And that's perfectly fine,
Perfect,
especially like we
okay.
have our triage because we see peds across our community hospitals as well. We only see peds in our children's hospital, but they are going to present to the closest site. So you want to make sure that that policy is intertwined with your pediatric patients.
Perfect. Thank you so much. I just wasn't sure if I had a feeling that was on there because those were really important ones.
Yeah,
and
those
I
are.
needed to make sure, but I really appreciate it. Thank you.
Thank you, Deanna.
Deanna,
is-
I think, oh, sorry, go ahead, Sally.
Just one more thing. It is really important and perfectly acceptable for you to integrate your pediatric policy within your adult policy, but it's not okay for you to just like, I surveyed a hospital one time that took the burn policy and just stuck the PD word in front of it. And it had no relevant applicability to the treatment of a pediatric burn. So though it's fine to do that, but make sure there is a relevant pediatric focus to that policy.
Absolutely.
Really good point, Sally. Thank you.
Absolutely. Thank you. Am I somewhat normal in the fact that this section is the one that feels a little
Oh, for
heavy?
sure.
Okay, thank you.
It's a lot.
Even as
Thanks for
presenters,
helping my anxiety about it.
even
very
as
small.
presenters, it's hard to say, okay, how can you make policies and procedures easily digestible and effective for you all to take and run with it? It's a hard topic to approach. The only other thing I wanted to add
of it.
Yep.
And so it's like, wow, that's heavy.
The only other thing I wanted to add to your question is, yes, in the toolkit and the assessment, there are suggestions and ideas.
Okay.
I would also encourage you to, if you have a particular patient population within PEDS, obviously, children, youth with special healthcare needs, whatever that might look like, or you have a particular diagnosis that your maybe staff are struggling to embrace a process on, don't do those as well. Don't just think, okay, I've got these, I'm good. Look at institution specific. I think it's really, we lose sight of, I can tell you some things at my hospital that we did that we really needed some help with and working on to make better that maybe weren't even on the list of here's the suggestions.
That's a great point.
Just
And
a
you have-
thought.
And you have a large volume of pediatric patients based on I mean, what you said, if you're seeing
Yeah.
about over 1,000
It's
kids
a
a month.
fairly decent volume. And the whole purpose behind this is my goal as the leader is even with that amount of volume, there is still some nervousness and I want the team to feel competent and comfortable and ready to go at any moment with those. We just have some work to do. We do a great job, but this is just tremendous and really thankful that you all have put this together.
And if you have a children's hospital that you can pair with, they may have some great evidence-based guidelines that'll help you with some of the things that frequently present to your ER. And they may be willing to share those as well, so that you are like meeting like evidence-based guidelines for caring for asthma and other things like that.
Perfect. And thank you for how willingly you all are sharing slides and information. It's very helpful.
Great, thank you.
Michelle, I'm looking back at the chat and I see several people commenting about the use of cap refill, documenting cap refill instead of
Yes,
blood
yes.
pressure. And I would say that cap refill is part of basic circulation assessment in a pediatric patient. That's
Yeah,
something
yeah.
that should always be documented. I can't say that I think it should replace blood pressure assessment because it's not the same thing. So
Yeah, no, I agree.
See that one of the last questions, does anybody have any good ideas of intake and funneling of feedback on what does and doesn't work on policies and procedures? Melissa, I'm guessing that your question is specific to your frontline staff and their feedback. I think a lot of times we think about I think in 2021, if you will, we safety huddle a lot. And you could carve out a little bit of time during your shift change or safety huddle in the emergency department to say, hey, even once a week, we've implemented X, Y, and Z new policies or new procedures this week. Any staff feedback on usability, easy access, so on and so forth. That's just one thought I had. I don't know, Michelle or Sally, if you have others.
Yeah, I think huddles are a great time to both roll out new initiatives or new topics or focus on something each month. But I think those are also a time to get feedback from staff. If you have staff that doesn't like to give feedback because they're afraid or whatever the case may be, because we know that happens sometimes, you can try just doing surveys or like even paper or SurveyMonkey or RedCap, whatever you have, that it can be anonymous, but you really do need feedback from people.
do you want me to share my screen and show a couple of these policies that I have pulled up just so people can see what the construction look like?
Sure.
Do I have
Sure.
access to share my screen?
Good. You see it?
Mm-mm.
Let me look here.
It says yeah, okay.
Now can
Oh,
you?
yeah, now I do. Yes, now I do. Let's see which one I'm looking for. So this policy is related to initial assessment and has some information. Oh, look, that's my presentation. What's
Yeah, I
it
was gonna say, we're seeing your presentation.
Duh.
And
Sorry.
if you guys have not looked at the ENA triage policy, they have a whole chapter on pediatric specific items and things to be considerate of. It's a really good reference.
Okay, I've lost my share button, Lisa. I had
If you
it.
move the mouse, is it there?
I don't know why. Let me see if I'm out of full screen, and that's what the problem is. I don't know. Let's see. Yep. There we go. Now do you see a policy?
Yes.
So this is this is an assessment policy. And you can see it's got a fairly lengthy policy statement. And then down here below are very extensive definitions so that it's very clear what an assessment is, what a focused exam is, physical assessment, psychological assessment, who's qualified to do that, what a social assessment looked like, and then the procedure for performing an initial assessment. And it's very detailed, and I want to thank the many of the EDAP nurses in California shared their policies and procedures with me in the last few days to be able to share with you guys. And I'll share all of these with Michelle.
Great. And remember, as you make policies and procedures, remember policies are really to guide regulations. And they have to be followed by like to the T, where procedures are, you have a little bit, they're how to do things and give you that little bit of wiggle, I think.
Well, I thought I had a second one pulled up, but I don't see it. That's too bad. I did have a second one pulled up that I liked. It was a triage policy. Well, sorry about that. Any other questions or things you guys want to discuss related to policies and procedures?
So
I
I
thi-
have a question. I think it may have been addressed, but again, super grateful for seeing the sample policies and just having those available. And I don't know if it's just school has kind of like really stuck with me. Then the whole concept of like plagiarism. So I don't know if it's fair to kind of take a policy and then just kind of tweak it to one's own organization to be able to make it something that's going to work for that facility. I guess I just want to make sure it is okay before I look at doing something like that.
I would say yes, and you can even if you have angst about it, you could even include in your references, like like I use an example from Cook Children's, or so you can give credit to the organization that you borrowed the policy from,
Or reach out to them if you found it on the web, reach out to
Mhm.
them and ask them.
And several of the policies that I will send to Michelle have been de-identified, so they're generic policies and have been provided so that people can use them. And Lisa brought up a point I should have intended to make, and that is how important it is to reference your policies. Wherever you're getting the information about, say, the red flags in the triage policy, for instance, if you got those from EMPC, use EMPC as a reference, or look and see where EMPC got that information. So references are really important, especially if somebody wants to go and read some more about that particular issue that you've brought up.
Thank you. That's helpful.
what else? Any other questions or conversations? Anybody wants to start? We have a good 9 minutes left.
And as you think about this, think about what is your aim? What % of policies do you want to create by a certain time? Or even defining that you want 100% of people to follow your new triage policy. It can be whatever it is you want it to be. And then really go through those key drivers and think about what parts do I need and how am I going to get to that? The more you can use quality improvement and show how you created this and what drivers, and really you can share that with people as you start to build that. It makes you start thinking about all the different components you need in a policy.
So somebody, let's see here, I don't have a name attached to it, just review process. So I think that this looks, this might look a little bit different depending where you are. I think, so for example, as a trauma program manager in my previous life, I even set my own reminders on my own calendar to review policies within an X number of years, for example. But my organization, where policies and procedures live, also have a specific policy around how frequently policies should be reviewed, revised, so on and so forth. So I think there's two pieces of it. If you, for example, are a PEC and you are building a program, you might start one of your initial policies or procedures may need to be reviewed a little bit more frequently, different from your organizational policy or process because the work is evolving. Or you might be starting to see more and more kids. So kind of carving that out for you as a PEC versus you as what your organization expects around policies and procedures. I don't know if I articulated that very well.
Yeah, I
Tyler or
think-
Michelle, you want to add on?
I think every organization has a policy on how often things have to be reviewed, whether it's 2 years or 3 years. And if you are creating new ones, it's really creating some sort of spreadsheet or some way to track your dates on all of your policies so you know when they're up for renewal. And you don't want them all to be on the same at the same time,
I agree with that.
because that is overwhelming.
I think another lesson learned from my organization is the policy owners and those who were responsible for reviewing the policy during that process were maybe not as close to the actual work as they ideally could have been. So perhaps as a PEC, you could, and I'm saying this, I was a leader in my organization as well. So I've been on kind of both ends. So I think that you can kind of maybe create your own process of when it's time for review and those formal reviewers are reviewing, maybe engaging some of your clinical supervisors or key individuals who are passionate about caring for kids and have them review as well. Maybe make, part of your review process.
And especially your frontline staff, because if they're the ones using that and having to follow it, make sure it works for them. I mean, there's certain things that they have to do and they don't get an option, but look at how it's written. And when there is wiggle room, give them that, see what works, and if it doesn't, ask what would work better. Rather than you can't just tell me it doesn't work. I really need what process do you think would work better? Make them
Sometimes
start
people need to
thinking
be
through.
asked. In a staff meeting, you might make a standing agenda item. Is there anybody who has feedback on a particular policy this month that they think they're struggling with seeing how it's implemented? Any suggestions about how those might be changed? I mean, sometimes people won't say a word unless you ask them.
Very true. Okay, everybody. Does anybody else have any other questions?
Great discussion, guys.
Yes. Thank you very much, everybody. And everybody have a great afternoon.
Thank you, you too.
Thank you.
Thank you.
Thank you. Lisa, I will not be on the after call.
Okay,
Thank you.
have a good
I'll see-
afternoon. See you later.
I'll see you
talk to
tomorrow.
Okay,
Bye.
bye.